Thank you very much. So I'm looking forward to this meeting, and so thank you for inviting me. As you will see, it's my standard talk, so it's a talk that I've been giving both at the European level, but at different universities and in different organizations. It's a stamped European Commission presentation, so you can do what you want with it as long as it's PDF. It's proofed by the European Commission. So just let's say in preliminary, I'm of course a professor of hematology and cell biology at the University of Paris, but let's say I finished more or less my active career in the last 5 years in programming research in France, both through the National Cancer Institute, the INCa, and also through the research organization Alliance in France, which comprises INSERM, Institut Pasteur, CNRS. So I was very much, let's say, hands-on in the exciting moments of programming research for cancer, but also the difficulties in getting funders and agencies to move differently, to think differently. So that's why I thought it would be a good challenge to be part of the mission on cancer. It appeared to me at this moment of my life in programming research in cancer that it could be an opportunity to make things move a bit differently. So that's my optimism. Maybe 2 years later on, I'm not as optimistic, but it's difficult for me not to keep optimistic. So I'll go through the mission approach, which I really find exciting. And I definitely hope that the European Commission is going to really hold on to this new way of programming research so that we can have more funds and probably more breakthroughs, because I do believe that if we think differently and work differently, that it probably adds on to the rest of the things that we've been doing quite well so far. So, why doesn't this move? Oh dear, it was working so well. Let's try this. Oh, good. Oh, too fast. So, we were launched. You can see the 5 missions here, and I'll explain to you why there's 5. So we were launched in September 2019. The Directorate General at the European Commission, which is dedicated to research and innovation, so DJRTD as we say, launched its first European Research and Innovation Days in 2019. It was their first time at organizing such an event. They did one last year at the same time in September 2020, and they're doing another one this year in June. So it's something which they believe is important, which I find interesting that they understand how it's important to get people together so that both sides, whether it's the European Commission or people outside the European Commission, understand and speak the same language. So it was during these Research and Innovation Days that the 5 missions were officially launched. That's my little pointer. Right. So why did the European Commission launch the mission approach? So it goes back into the interim evaluation of Horizon 2020. So let's say it's somewhere around 2017, 2018, where they made an evaluation of Horizon 2020. And unfortunately, they had very negative feedback from the citizens, saying that they did not understand where the money given to research was going, and they didn't understand what was visible in the research outcomes. I always speak very freely so you can understand. The European Commission has to fight to get the budget for their research programs. They have to go through the presidents of the member states. They have to go through the parliament. if there's a citizen which says that they don't understand where the money goes for research, it's a bit difficult to ask for more money for research. So it was really something that they thought should change. They were also very much aware that sometimes research stays in PubMed, or I don't know, in some sort of archive, and does not go into real solid innovation. So in their strategy that they launched in 2018 and 2019, they decided for the next research program, so a Horizon Europe, that they would put 2 extra, let's say, initiatives. One is the European Innovation Council, and the other one were the research and innovation missions. So the missions fit into the different types of pillars that maybe you understand or you don't understand, but it's not, let's say, that crucial. You can see on the left things that you probably know very much about, the European Research Council, what was previously called the Marie Curie actions, but well, maiden name of Marie Curie came up, so Marie Sklodowska-Curie actions, research infrastructure. So as you can see, this was not meant to move, so it stayed. The second pillar is dedicated to, let's say, everything. And that's where you have health, food, digital, and that's where the missions fit in. And you can see in the bubble right up at the top that they really thought that this mission approach needed an extra budget to do things differently. And it was said, and so far it is still said, that the missions would have 10% of this Pillar 2 budget for their actions. So it's something which is concrete, written in solid marble at the European Commission. The only thing which worried us a bit for a moment is that it was decided and thought by the previous European Commission. So 2018, launched in 2019. And as you know, the new Commission was launched in 2019, December 2019. So the new Commission did not follow the need, the enthusiasm of the mission concept. So it was important for us and for everybody at the European Commission, and of course, people who were in the DJ Research and Innovation who participated in this approach to communicate and explain the potential of such an opportunity. So this is a highlight of 3 documents describing the mission-oriented approach for research and innovation. So the document you can see here right at the top here, that's the summary of the preliminary report, interim report, sorry, that Pascal Lamy did. And that's where, as I told you, it came out very positive things like ERC and etc. But the fact that citizens were worried about where the money went. And so the European Commission asked Mariana Mazzucato, who's an economist at UCL in London, to see how to, let's say, formulate and apply the mission-oriented approach to research and innovation at the European Commission. So she produced 2 documents, which are very easy to read. One is published in 2019, which summarizes a mission-oriented research and innovation in the European Union. And in 2019, she was asked to formulate a bit more precisely how one could see the governance of the missions in the European Union. And so that's the second document that she published in 2019. So this summarizes, let's say, work which appeared, well, certainly new to me, new, of course, in the field of research and innovation at the European Commission. But the mission approach is something which is well known in the economy field and which has already been used in different European countries at least to tackle different challenges, very often at the level of the ministries. I've just highlighted a few of the sentences which are in this document, which I think illustrates well what the mission approach could do differently. So the sentence here is that missions provide a solution, an opportunity and an approach to address the numerous challenges that people face in their daily lives. So things which are here, which are important, is that we have to provide a solution. So it's not something that is very easy for those who have been doing research, and it's not that, let's say, a tangible result. Address the numerous challenges. So it's important that it's directed to answer a challenge, and then the people face in their daily lives. So we really are in the concrete needs and concrete needs as identified by citizens. Sometimes it works, sometimes it doesn't. Two other sentences. So mission's goal is to involve citizens and stakeholders more closely in setting research priorities. The not only is very much important, and you will see that with the examples I will give for the mission cancer. If you want to answer a challenge and a need of a citizen, and also for cancer, we have patients very much identified. It's just not research which is needed. It's also a lot of policy support actions, which is why this has been really thought of in the mission-oriented approach. Even if it's for research, it's not only research priorities that are put together with the citizens and the stakeholders. So we put everybody, we involve citizen stakeholders more closely, and we set research priorities that will lead to equal access for everyone in Europe. And so that's because we are, of course, in the European Union. So it's a major difficulty in this mission approach at the European level, because when it's used in one given country, it's maybe not that easy, but at least it's one country. In the European Union, we have to address equity, and therefore we have to make sure that the actions answer citizens and their challenges at all member states, and that the solutions are adapted to the needs of each citizen at the European level. So how do we, how does it, let's say, implement and move forward? So once we've just got these research priorities identified, then the way to move forward is to set clear, ambitious objectives that can only be achieved by a portfolio of research and innovation projects and supportive measures simultaneously and not one after another. So this is the new part. This is what I believe is something which I haven't seen done very much in research programming. You're allowed to have ambitious objectives. You don't need to have that much preliminary results. You can go for projects which are ambitious and at risk. They're so ambitious that's why you need to work together with the citizens and the stakeholders very closely. The word co-design is said all the time. And as it's complicated and difficult, the only way that the solutions can be achieved is by accepting that you can have multiple projects and supportive measures that can be launched at the same time. Meaning that you cannot answer the challenge by just one, let's say, project or research call. And meaning that as you are launching different approaches at the same time, well, if one is not working, then you stop and you have the other ones and you move forward. So this is, I think, the very good possibility that is offered by the mission approach. So in concretely, how did we manage this in 2 years? So first, the challenges that the European Commission identified are these 5, and therefore they provided 5 mission areas. On top you have climate change. Here you have healthy oceans, plastic, sea, coastal and inland waters. Climate neutral and smart cities, healthy soil and food, and there's only one which is directly linked to health, even though we can imagine that all these 4 others are also linked to health, but there's only really one dedicated to health, and that's the mission cancer. I wasn't, of course, in the deciding process of the health challenge being targeted to cancer. One of the main reasons is that, as you know, if we don't work and do things differently, it's expected by 2040 that cancer will probably be the first reason, unfortunately, of shorter survival in the coming years, taking over cardiovascular diseases, which is for the moment the first cause. So the 5 missions is a new concept, a new way of working for the European Commission. So it's all very well, let's say, monitored. We all work in the same manner, and we all give our reports in the same way. And so it's more or less very well, the frame is very, I was thinking of strict, but well, it's very well defined. So the mission areas, so that's 5 mission areas, and each mission area has a mission board and an assembly, which is linked to the board. So we are, at the mission board, we have a role of advice, right? So we give advice, we collect information, and I'll show you how we did that, and we give advice to the European Commission. And we hope that the advice that we give is understood and that it will be sufficient for the European Commission to be able to set out the calls, set out the support actions that we believe are important. So here is summarized what I've already told you: 1 or more ambitious missions with input from stakeholders and citizens, characteristics of project portfolios for missions, how best to achieve the objectives of the mission, to communicate, policy coordination and synergies, and then of course to give our ideas on how we believe the monitoring of these mission actions are meant to go forward, so that we are sure that in a certain number of years we will be able to have the concrete results and solutions that we were meant to find for the citizens' challenges. Whoops. So that's the Mission Board of Cancer. So there's me. I'm vice chair, and I share therefore the chair with Walter Ricciardi, who's a professor of hygiene and public health in Rome. So all missions have a board of 15 members. And so you can imagine the difficulty if you've done research programming and committee organization. So the European Commission had to, of course, find a different, let's say, interest and expertise among the 15 experts, so that we can more or less answer as much as possible the different needs. We do not, of course, then represent all the member states, because 2015 is not 27, but I will highlight a bit later that we share ambassador role for, of course, more than 1 country. The Mission Board on Cancer and all missions, so it's just not the Mission Board of Cancer, also leans on 26 experts, which are assembled in what is called an assembly. We were meant, I mean, all mission boards were meant to interact with the assembly members once a year. We've done it more often than once a year. We do find it very important to engage with other experts in the cancer field, which brings that most of our work can really lean on more than 40 experts and not just 15. So these are the 15 members of the Mission Board on Cancer. I forgot to say also that different in expertise, but they also made sure, of course, that we had the same number of men and women. And these are the members of the Assembly. So I've just highlighted again that for, let's say, coherence, the chair of the Mission Board is also the chair of the Assembly. So what did we do to try and identify the challenges, the needs, and then the way to move forward, and most importantly, how people wanted to move forward, who had already initiatives and priorities in their member states that were already moving in the right direction and that they would like to share. We needed to go, as you understand, in a co-design approach. Therefore, in the co-design, we needed to be sure that when we brought out recommendations and ideas, that we had sufficient backup, that we had sufficient endorsement of our ideas, so that it just did not come from 15 or 40 experts at the European Commission, but that it was really something that was more, let's say, comprehensive in what the European Commission experts and stakeholders involved in cancer thought things needed to be done. So we engaged, and now it's more than 100 meetings with citizens and patients. And we also had ambassador activities, which I'll describe a bit later. So citizens engagement, it was something, of course, that we really needed to really get a very strong feedback. We were a bit light on citizen. We're a bit, understandably, overwhelmed by patients, by carers, by parents, when you deal with cancer. But if you want also to go into the field of prevention, which is something, of course, that you can understand is crucial for cancer, we need also to reach out to the citizens. And so we had the difficult task that I thank the European Commission to give us the right format to engage with citizens in the member states, in meetings where we were able to do these consultancy in the natural language, which was, of course, important. And we also had, by different types of surveys and different type of classes, because it went on for more than a month, with different meetings, with specific focus groups, which were done in English, unfortunately, but which allowed us to be able to contact as many countries. And so now we can say that we have feedback from all the member states, and not just the usual suspects like France and Germany and Spain and etc. So we're quite happy to have some new ideas and some new ways of formulating the needs and the questions and the weight that each of these needs were defined by the citizens and by the patients. If we have to hope to deliver solutions for each EU citizen at each member state level, then we really have to convince and work with the people who are in the member states. And so that's where we defined ourselves as ambassadors. So of course, we were an ambassador for the country we came from. So I was, of course, the ambassador for France, but I'm also the ambassador for Slovenia. So we managed to cover all the 27 member states. And so that's the work we did, working with the ministries of research, health, economics, and education, depending on how the countries organize the cancer research and policy in these states. We worked also in these member states with the citizens' engagements at the same time, the national stakeholders. And so for this, it was really very important for us. And it was also crucial that we were able to lean on written documents that we've received. I don't know how many documents we've received, and some organizations probably sent 2 or 3 or more as the 2 years went on, to be able really to endorse, criticize, give ideas, and most of all give support, which for us was very important. And the European Commission did quite a few online surveys. So there we were. So after this major work of consultancy with which you can see here, citizens, patients, carer, member states, authorities, the EU and national stakeholders I've talked to you about. Of course, we also listened and questioned all the different opportunities that the different DJs and the European Commission has already to provide any sort of support, not only research, which could be helpful. And we also worked very, very closely with the members of the European Parliament. And I'll just stop here a bit. I will come back to it later because it's important. So I said that the missions were launched in September 2019. The new commission started in December 2019. And as soon as she arrived, President Ursula von der Leyen said that she wanted to have a beating cancer plan, a European beating cancer plan. And so it was a wonderful opportunity for us at the mission on cancer. We were also therefore leaning on another EU initiatives. So we have 2 EU initiatives now to We Conquer Cancer and They're Beating Cancer, whatever. So it's very crucial. And it was really very important for the members of the European Parliament to also take this cancer field, cancer area at heart. And so there are 3 committees of members of the European Parliament who are working to be able to provide the right support and to monitor that things are being set up and the budget is being set up as it should be. And so for us, it's also very important that the members of the European Parliament participate very, very much in this work. And so all this led us to give in our report at the Research and Innovation Days that was held, as I said, in June of last year. And so this is what our report looks like. All the 5 missions gave in their report at the same time to Commissioner Maria Gabriel. And so we were limited also in the number of pages. So it's quite easy to read, and this is how I'll finish my next probably 10 minutes or a bit more on describing to you what we recommended to conquer cancer. So what we have to do for a mission approach, if you remember, is to have, of course, ambitious actions. But we need to have a specific target that is quantifiable in time. So it's not something which is very, very easy, maybe for cancer, but for research, it's not that easy. But we got down and thought, and so we came on by, so the date, by 2030, so we pushed it a bit because theoretically the health program of the European Commission ends in 2027. But so we thought that by 2030, we wanted more than 3 million lives saved, but also living longer and better. And so this house, which now the more I see it, the more I find it important, which we built in our different discussions in, I think it comes back to December 2019, and now it becomes very, very important for us, and I'll tell you why. So to be able to reach this goal, we have identified 5 intervention areas. So you've got these 3 pillars, which is prevent what is preventable, optimize diagnostics and treatment, support quality of life. These 3 pillars to reach the 3 million lives saved, living longer and better, need to lean on a very solid ground, which is understand. You cannot improve what you cannot understand. And because we have to answer the needs of all the European citizens and patients, we reach out, of course, to this floor underneath the roof, which is to ensure equitable access to all. And so to be able to try and reach these 5 intervention areas, we defined the 13 recommendations for bold actions that are all citizens and patient centers, and I'll describe them to you in the next slide. If I come back to why we believe now that in fact this house is important, you can imagine if you're, I don't know who decides all these money distributions, they're called the Strategic Commission. They say, okay, so where do you want to start? Which are the actions that are most important for you? We believe it's important as mission board and the assembly members that all these 5 intervention areas are important. And if we put more money or more efforts in one pillar and not into the other, the house doesn't stand. So for us, it's important that to reach the goal, we need to have support adapted to the efforts that are needed and to the gaps for each of these pillars and the understand floor, so that we really increase the number of lives saved and the quality of life and the length of survival. So this before last slide, so that we have time to discuss and we can come back to it. These are the titles of the 13 recommendations that are in the report. So I've been, as I've said, presenting this for a long time. So I know some of the, let's say, comments, and I try now to be able to take a few steps in advance and say that, for example, the numbers that not imply that it's a priority ranking, right? So the recommendation 1 is not automatically the first one, right? And I've said how we believe it's important that we move together in all the fields that need to be developed. What's also important is that we worked in groups with ourselves, with the different people, and so the recommendations are a summary of the way we want to move forward in a specific context, and the actions that can be linked or that are necessary to let's say solve these recommendations or implement these recommendations. The actions can of course answer more than one recommendation at the time. So things automatically sometimes go together. It's just that the titles for us and the way we wanted to recommend our ideas was really in this aspect. So I'll give a few words for each of these. So the Untitled EU platform is, let's say, the most basic research action, a recommendation that we have brought forward. It's linked essentially to solve the cancers that are very poorly understood. So it can be pediatric cancers, but it can be also cancers like breast cancer, which theoretically are well understood, but we have the triple negative, which are not at all understood. It can be some prostate cancer, for example. We don't know exactly how it arises. We don't know what the prostate cancer normal stem cell is. So it's really to be able to work on and provide solutions for the poorly understood cancers. It's of course here to bring all the expertise and the information together. So it's a virtual platform. Of course, it's not a building that we want to create. It's bringing the information that exists everywhere, and to make sure that once somebody wants to answer a specific challenge on a specific cancer that is poorly understood, we know where the expertise and where the information is. So it can be gathering information from different research infrastructures, but it can also be knowing where the samples are. It can also be knowing where the data is. So it's quite large. More specifically for this recommendation, the European Commission has already launched a pre-phase to define how this platform should work, and the call should be coming out. It was meant to come out in May, but the research program is being pushed back to June. So we're nearly there on the CSA to be able to define the blueprint of what this could look like. Next is linked to genetics, but not the genetics of tumors. It's genetics of the population, to be able to identify in the population different types of variants that research can identify with specific risk scores for different sorts of cancer, but also for other diseases. So it's the polygenic risk scores. Then, of course, we have quite a few, let's say, irritation from the cancer field, because a lot for prevention strategies and policies, and I'll go back here also on recommendation for screening programs. All this has already been very well discussed. The strategies and the guidelines have already been written, but it seems that there's a difficulty in implementing these guidelines and strategies in all member states. And so it's really a commitment that the board members wish to set forward before anything else is being done. Of course, as you know, 40% of cancers can be prevented, and it's also much better to have an early detection for the prognosis, so optimize existing screening programs. Of course, it was important that the word personalized medicine was identified. It seems to be something which is currently so much used and so much discussed in different means that we just thought that it would be good enough to say advanced and implemented. But once again, the challenge is for all cancer patients in Europe. And it's difficult to be able to have the diagnostics tools and also the drugs and the techniques at the disposal of all the physicians in all the EU member states. Early diagnosis, minimally invasive treatment and technology. This for us is very, very important, very much linked also to research, fundamental research. This is where you can also have the liquid biopsies, for example, and much of the treatments that you can have with radiology, radiomics, and all different types of devices which are crucial. A very important recommendation to improve the quality of life It's something which, it's a research field which is very, very weak, not very research, let's say, stringency so far either. But we're going to have, as you know, more and more, not only the cancer patients, but we do have now a very important, thank heavens, population of survivors. We have the family members and the carers that also need support. And we're going to have, and we already have, all this population, which does not have a cancer yet, but which has been diagnosed with a risk of having a cancer. And so this is also a population which needs very adapted support. We thought that to answer some very much required needs from the patients and the survivors is to have a virtual place where they could find information about their cancer. And you can imagine, what's my cancer, where does it come from, where can I have it treated, how is it treated elsewhere, but also where do I have the information on my own cancer history. So to be able to have in a specific place all the documents and the recommendations that the physicians have given to the patient, that he can really have, let's say, in a specific app. And we believe that if the patients have this possibility to manage the information they want and also manage their personal information, that this personal information can go above what the physicians and the laboratories gives. They can also define how they feel, what they let's say, feel as a side effect or in their everyday life. And so all this data, which would be in the hands of the patient himself or herself, could then give them the possibility to share. And therefore, it could be possible with the patients to be able to decide, with all this data that they have, how they can share their data so that some of their needs could find the right research setting to be able to solve it for themselves and for other patients. For the cancer health equity, I've already told you a lot about that. For us, it's very crucial and important. It's linked to this recommendation of a network of comprehensive cancer infrastructure. So we've put infrastructure because we wanted to be as vague as possible. It's not automatically a comprehensive cancer center. It's not only care, even though we have to start by having quality of care as a minimum. But we really want to push forward the idea that care and innovation, and the best care and innovation and up-to-date care and innovation, can only be reached if a cancer care center is linked with research and with training. And so this is what we understand as an infrastructure, a comprehensive cancer infrastructure. And so we would like to be able to provide to the patients at least one comprehensive cancer infrastructure in all member states, to be able also to link all the existing comprehensive cancer infrastructures in each country where there is some in a national network, and then bring everybody together in the EU network on comprehensive cancer infrastructure, where the dynamics would be able to look at what the other infrastructures are working on, how they are progressing, how they bring innovation to the patients, how they have accreditation facilities, accreditation for care, for surgery, but also accreditation for phase 1 clinical trials, accreditation also for maybe up-to-date registries and data, quality of life interventions. So the networking and the sharing among these national networks and comprehensive cancer infrastructure for us should be sustainable for life, and should be able to provide incentives and hopefully trustworthy and even friendly mean for all comprehensive cancer infrastructure to always reach for the best excellent level for care, research and training. Last of the three ones here, of course, a dedicated one on childhood cancers, cancers in adolescent, even though there are very, very much, let's say, indications in all these previous recommendations, how they can really answer the needs of childhood cancers, which are really specific. There's this one, which is a bit like the personalized medicine. It's something which is really very current in all research programming and innovation for cancer. So we would like to accelerate the innovation, try and find, if it's possible, what makes it so complicated to have so many biomarkers, for example, in PubMed, and only so few which actually reaches the patient. Is it the patents? Is it the difficulty of the member states to understand? Is it the way the researchers provide the data, which is not sufficiently solid or adapted to what the HTAs ask? And so we also thought, to be modern, that we could lean on the oncology focused living labs. We believe that the living labs, which most countries have already set up for different types of research, represents a way to design research which is very close to the mission. You know, you get this co-design with citizens and different stakeholders to answer a specific question. And so maybe this could provide a new way to accelerate innovation and implementation for cancer. And then this recommendation 13, which for me is really, I can't say it's the most important because I've been telling you that they're all important. But you can realize if you're in the field of cancer that, and I've said that I've known Jean for more than 30 years, so I've been in the field for a long time. The cancer 30 years ago is not the cancer that we see now. And I'm not quite sure, and that's what we believe, is that this hasn't reached everybody's understanding. Whether it's at the policy decision-making, the HTAs, the lawyers, the insurers. And so trying to move this knowledge into what we title Transform Cancer Culture is to make people understand more what the challenges of cancer is and what a true cancer patient is. There's as many cancer patients as there are of different types of cancers. And so of course this goes through communication, which the patients really say how crucial it is for them, that there is a better understanding by the society of what cancer is. It would reduce discrimination that they say they suffer from. And then the last, capacity building, which goes also through what we always believe, that if we improve the skills of the people who deal with cancer, things will be much better. But it's not only the skills. We definitely want to underscore that it's also, we need more people to work on cancer. So it's increasing the capacity of our field of cancer to what it should be, and not just rely on the existing goodwill of the people who already work on cancer. It's just not, let's say, continuous education and improving the skills of the people we already have working on cancer, but moving forward. So this is where we are now. And so I can't say we're finished, but we're nearly finished. So pragmatically, this mission board is going to end in July. We have handed in, as I told you, our recommendations in September. We've been working with the different stakeholders in trying to make our recommendations a bit more concrete, a bit more, let's say, understandable for the European Commission to see how they can define an implementation plan. So the different DJs are finishing writing the implementation plan of the 5 missions. And these implementation plans are then going to be discussed with backwards and forwards between the Strategic Commission and the European Commission to be able to define the way to move forward and the budget which will be linked. So two words here. So this is the logo of the European Beating Cancer Plan. So we were very happy to work with DG Santé from the beginning in September of 2019. And so all the meetings and all the work of the mission board was done with the directorates of the mission of the DG Santé. And so it's why, and that's why we're very happy that our 13 recommendations are also seen in the work program of the European Beating Cancer Plan. Some words are exactly the same, some actions are exactly the same. Sometimes it's adapted more to what a cancer plan is and a bit less than what we are meant to be in research and innovation and in the mission approach. But it's very important for us that we know that our recommendations are already taken up by such a great endeavor as this European Beating Cancer Plan. To make sure that the way that the mission moves forward with the Beating Cancer Plan is harmonized and flows well, we have now, since March, a dedicated manager for the cancer mission, who is Patrick Child. And the deputy manager of the cancer mission is John Ryan. And if you do not know, John Ryan is the DG Santé director, which is behind the Beating Cancer Plan. So this is really for us showing how things are going to work really hand in hand to make sure that we hope that the missions will be able to deliver, and we hope that these two opportunities to fight cancer are really going to work as unfortunately everybody expects it to work. And I mean, we've never had that. We've never had such an opportunity to fight cancer at the European level. The European Commission has worked very solidly in these 2 years, despite the COVID crisis, because it's the same people who also work on the COVID crisis in DG Santé and DG RTD. So we really hope that this opportunity, which we have now, we're not going to fail. And so with this, I'll end, and I'll be happy to answer your questions. Thank you.
Thank you, Christine. If we can go back to the main screen, and I would appreciate if you could turn your cameras on. As always, who wants to start, raise your hand, either on the screen so I can see you or on Zoom.
Well, I'll have to do it like this.
Go ahead, John.
Can I start? Well, thank you, Christine. I mean, it's a fantastically ambitious and super plan. And I liked your opening statement that you wanted to think differently. And I agree. I think the document has a lot of different thinking in it. And I picked up on your very last slide, this thing about transforming cancer culture. And my question is about culture, really. I read the Porto Declaration, well, 2 weeks ago, something like that. And I saw at the center of this are the comprehensive cancer centers. And I wondered what you thought about putting them at the center of these various activities, the various pillars. Because my understanding, and I've had a look at them, is they're very dominated by medical oncologists. And the medical oncologists are very much in, how shall I put it, collaborate very much with the pharmaceutical industry. And they have a vision of treatment. And some of the expertise that you're looking for, particularly in early diagnosis and detection, and which should be in the community, not in these centers. It should be out here, you know, in the laboratories in the street, just down the corner here with the GPs. And prevention, I don't see that these comprehensive cancer centers have that expertise in behavioral science, in social science for prevention. So how do you see their role? Are they not a bit of a threat?
So they're not in what you are saying. I mean, it's not, it's for the moment, it's not their role. For the moment, it's a very simple answer to the patient in all member states to have quality care. Baseline assurance that the same guidelines are more or less adapted to each country, and that a patient who is in Bulgaria, for example, Romania, can have at least the basic guidelines that are expected, for example, in ESMO, ERTC, or whatever. The patients also want, so they need to have the diagnostics and the care, which should be standard. Once they've got that, and then it's after that, because it usually doesn't work all that well, right? They would like to be able to have access to the innovation, let's say, trials. And so they would need also, maybe not in the same clinical cancer care center that they went to, but at least in their country, they know that there's another, what we call the comprehensive infrastructure, which will be accredited, because it needs to have some sort of accreditation, to do clinical trials, to do. What we hope is also always leaning on always keeping in mind that we're centered on the patient. So the patient already has access to care and to innovation. The patient has to have access also to his information and to his data. And so this is not done. I mean, even if I take France, I mean, even in my hospital, Hôpital Saint-Louis, we're just basically trying to get everything in digital form and out to the patient, right? So we want also these centers to be able to put some sort of initiative so that the patient can have his report each time he goes and see a doctor, right? He can have the summary of his MRI. Right? And so this type of data and the infrastructure which is needed to be able to push this forward can only be done, at least at the beginning, in specific infrastructures. And that's what we believe the CCI should be able to do. And so if we go along there, then maybe after that, the patient will be able to provide what he needs, the information he thinks is important, for example, for behavioral research. And the only thing that we believe that can be linked to prevention, and what you say is exactly true, it's not their role to do prevention, but prevention is important. We hope that maybe they could be more, let's say, harmonized in the way that they do the registries. Right? Don't forget that we're talking about, when we talk, most of the time we have specific member states in mind. Not the ones who know exactly how to do it already or have specific structures. It's really trying to, so yes, so for us, the CCI are not going to be those who are going to do fundamental research. They're not the ones who are going to do the behavioral research interventions, right? We believe that, however, once these infrastructures have been identified, if the European Commission sets out a specific call for new ways of communicating, for behavioral research on a specific side effect or quality of life, we hope that some of these CCI will say, yes, I want to participate. But it's not, I mean, it will be on a voluntary, hop and on, twinning, whatever you want, but it's not, no, their mission is really to answer what a patient wants, care and innovation and good care, yeah.
Thank you, Christine. We're out of time, so it needs to live sharp at 15 minutes past, so please keep your questions very short, and we still have a bit of time for questions. So Lydia, you next. You're muted.
Yeah.
Thank you.
Thank you. So I will be very precise in my question. It's regarding personalized medicines that you have there. So the definition is quite unclear today, I think, because it's a definition of the Council, which is broad. But when we see what is now in the Europe's Beating Cancer Plan, it's just talking about NGS sequencing and treatment based on DNA mutations. And then that links to my next question. How do you link that type of personalized treatment then to the goal being living longer and better, overall survival, where we know today there's a lot of uncertainty about that link, and how will that be monitored? Will registries keep track of the overall survival data? Not the case today. It's very difficult to have treatment results in registries. So how will all of that be managed, and how will we be able to really see the impact of the new innovative treatments, targeted treatments, personalized treatments on overall survival?
Yes, so so we have a broad definition of personalized medicine, which is not just linked to a DNA mutation, or even a protein, right? Like immunotherapies, right? No, we do not want to limit personalized medicine to only drugs. Personalized medicine is really what a patient, what treatment a patient needs for his own tumor, but also for his own way of life and his own needs. So it's much wider than just the drugs and GHGs. Now, how to monitor this, of course, is very difficult for us, right? Because we've given recommendations for the monitoring. We don't know how it's going to be done. We believe that registries we could lean on the existing surveys. We can lean on what is already existing, but it will be also important to develop new types of information, and that links to the quality of life, of the outcomes, and to be able to do surveys and to lean on the data of the history of the reports, the PRMs, because sometimes what's written there's information in what is written, which is not automatically accessible if we give a questionnaire with a very precise question and an answer. So we don't want to also lean on, we want to lean on unsupervised surveys, but that's research projects, right? So we have to lean on what is already existing, because what exists is already very strong. If we want to be able to measure, we need to also lean on what is already there and to reproduce it in the coming years, so that the measure is already there. But we also want to develop research so that the surveys and the information is wider.
Thank you. Any other questions, comments? I have a quick question. It's more in the title of your presentation, but it also comes across missions in the US and I would say across the globe. I think we're all passionate about figuring out what to do to conquer cancer, but I guess the question is more of semantics and the use of words, because you as a hematologist well aware that we've succeeded tremendously in curing some cancers, and we're nowhere close with quite a lot of cancers. And the way biology works, conquering becomes a very hopeful statement. And this is something that pharmaceutical industry would like to pronounce and put on billboards. And how does this word play with marketing, with the European Commission, and where does the truth fall with it? So
the truthful, of course, conquering cancer and beating cancer is an incentive, right? We're all there in the front, and let's charge, right? So I think it's more of a logo, and let's go for it. However, for the mission, when we say 3 million lives, the 3 million is not because we've put 2030 before, and so we thought that 3 would be good to link with 2030. The 3 million live slaves are really lean on extrapolation, on data that we already have from Eurostat or others, of what could be achieved if preventive measures and early diagnosis could already be there. We also, and that's, let's say, 40%, right? We also believe that by increasing the care, the standards of care, and by increasing a small number of policies that have not been really implemented in all member states, we could really prolong survival in a lot of cancer patients. If we could raise some survival for some member states close to the level of other member states, then we will really have achieved more than these lives. No, so for us, it's not, we were very careful, because once again, it was the major challenge of the board members to try and put something which was quantifiable and achievable. We do not want in 10 years' time people telling us you provided hopes and figures that you could not hold. So we hope that what we've written, we believe that it's achievable if, of course, the interventions and the recommendations are followed.
Thank you, Christine. So we have a few more minutes. If there's another question, quick question.
I just want to comment. I think that's very pragmatic. It didn't really strike me about the 30%. That, of course, in some countries in Europe, and even looking at the British Isles, Scotland compared to London has huge disparities. It may be the same in France. So I think that's a very genuine goal, which hopefully is achievable in a different way from the way that many people perceive it. It's not the way that Biden sees it, I don't think. It's really bringing everybody up to the level where we are now. So that's very important. I just had a final question to you about citizens. And I think, how would I put it? The problem with citizens is that they want cures. And getting over a culture of early detection and prevention is extremely difficult. So I just wonder, in your consultations, did anybody suggest from the patients that there was anything other than looking for cures on the agenda?
So it's not the major message that we got from the patients, right? When you talk to patients, they say, I want the best cure and I want the best treatment. Some did say, what could I have done to prevent where I am now? And what should I tell my family or my friends to change? So of course, I mean, even I had patients who said, should I eat differently? Is there something, let's say, it's not just the way you eat that's going to stop your leukemia. But yes, a few really want citizens to understand better that there are maybe things. I mean, for example, melanoma is something very crucial, and even lung cancer. They really want to try and make sure that the information. So the family is more or less convinced, right? Because they're very, very close. But it's really, they really wanted to go further. There's something I haven't said, and I can just take this opportunity. We really want to also to lean on what we've learned with the COVID crisis. There's really a lot of things which have worked very well, some of which have not worked very well. And there are really, to how people perceive risks. I mean, they definitely believe that AstraZeneca is, of course, more dangerous than to take your car in France and go driving, right? So I mean, so it's true, and the risk and the way that people have put masks, quite easily, after a few minutes. I mean, there are things which I think we've learned. We've also learned that we were waiting in France for the European Commission to give its decision, even for the pharmaceutical companies. We had all the ministries of health, which had 2 or 3 meetings a week to be able to decide how each member state should work together. Even though they do not work together, they had their own specific ways of moving, they were still exchanging ideas, and we are not completely different from one attitude to another. And this is something that we hope may continue for cancer. The behavior, the risk perceptions, and getting eventually the member states' ministries to work more together so that they understand that COVID is a crisis, but if they're not careful, cancer will be a crisis. We still die more of cancer than we do of COVID.
I can just add that this morning I had a blood test, you know, to do my cholesterol and all the rest of it. And the PCR queue was right down the street. And this is great. I mean, I think you're quite right. I mean, if people begin to think, well, I can prevent myself from getting this. So it's a very positive way to move forward.
So I hope we don't lose this.
Yeah.
It's like when you've been, you know, burglared, you double check your door for 3 months and then you forget. So I do hope that this momentum is kept and we can really use it in a good way.
Yeah, super.
Thank you, Christine. On this note, I have to close today's seminar. Safe travels, Christine. Thank you so much for your time. Very informative talk and short but nice discussion as always. So I'll see you in 2 weeks.
Thank you all very much.
Thank you.
Lovely
Very
opportunity. Good discussions. Bye-bye.